Well, welcome everyone. How's everyone doing today? Good?
Good.
Awesome. Well, my name is Nathan Jones. I'm the MILI grad assistant here at Carlson, and I'm very excited today to welcome you to our first in-person EIR session in 2 years, Pinar, right? Like 2 years, so great day. And on top of that, we have an amazing guest here to join us today, Mr. Gopal Khanna. I was looking at your bio and you've done a lot of stuff. You spent a lot of time in Washington, D.C., working with the administration there, also here in the local government, with our governors here in Minnesota, and wealth of knowledge. The topic for today's discussion is really the healthcare ecosystem of the future. So he's going to share some great insights, and this is really meant to be a collaborative, really informal session. So we encourage participation, ask questions, think of it as like a coffee talk. And for those that are joining us virtually, thank you for doing so from home or wherever you are at work. If you do have any questions, we ask that if you can possible, unmute your camera as you ask the question for Gopal. Otherwise, looking forward to the conversation for today. So without further ado, we'll invite Gopal up here.
Thank you. Good morning, good afternoon, everyone. Can you hear me? Because with this mask, the voice can be a little bit muffled. Can you? Okay, all the way back. And those folks who are virtual, can you hear me clearly? Yes, no, maybe so. Since I don't hear anything, which means yes. So today what I want to talk about is the healthcare sector large. But healthcare, as you might know, is about 17% of the US economy. So GDP is about $17-18 trillion, and about $4 trillion is close to that is just healthcare. It's a huge sector, very complex, too many things are happening. So what I did was today, I said to myself, let's come down to some real stuff that's happening and share with you not just all the challenges, but also specifically a use case. So what I'm going to do today is talk about leadership opportunities. You're all here at the University of Minnesota. Thank you so much for taking interest in MILI. It's a phenomenal program. Thanks to the director here, Pinar. She just has set up a terrific vision of what MILI can make happen for you and for all of us. So when we talk about leadership opportunity, the question is when and how and where and why and what. So there are a lot of many questions. So what we're going to talk about leadership opportunities in the post-COVID-19 era. Now, COVID-19 has really taken out 700,000 lives. Fellow Americans have lost their lives. And it's a lot. My heart breaks when I talk about it because it shouldn't have been. It was a disruption that has happened in our life that was not anticipated, not expected. And what it has really done is forced us to think about what healthcare ecosystem would look like in the future and how do we position ourselves, whether your area of interest is pure research or practice, clinician, we have with us a clinical practitioner, or any management folks, or someone who's involved in recruiting future leaders. So what I'm going to do is set the stage for what's happening and then talk about innovative leadership opportunities for you. And when I say that, I'm going to focus about, again, disruptive forces, what, how, and why change must happen, and how you drive change, and a use case. So let's talk about what's happening in the industry. COVID-19, I call that as the mother of all disruptors in the last 100 years, literally, because it has come upon us literally from nowhere. We're not prepared for it. In any and every aspect of delivery of care. And what is also happening at the same time is there have been change, ask for demands for change happening over the last 5, 10, 15 years. To me, one researcher, genuine researcher when it comes to management principles is Malcolm Gladwell. If you have not read his book, Tipping Point, I would recommend that you do, because it applies to anything we do in all walks of life. Basic thesis of Malcolm Gladwell is that when forces are happening, there has to be a tipping point for big change to happen. So when we look at the disruptors, demographic changes have been happening for forever. Every census reports a different demographic mix. Customer expectations, doesn't matter which industry you're in, are constantly growing and expanding. So when it comes to healthcare, clinician expects better quality care, period. It's all about quality of care, and they expect it to be at reasonable cost. As we have seen this past year, there are serious access and inequity issues in the delivery of care. PNR has devoted much of her time looking at health equity issues as a researcher. Delivery systems executives are concerned about. Government is concerned about. Constituencies are concerned about. And the access and inequity gap has been increasing. But if you look at that all by itself over the last 5, 10, 15, 20 years, it means nothing. But when you see that in the context of all the drivers that have been happening in the marketplace that demand and expect change, citizens today, we live in a virtual environment. We expect delivery of care on demand, as and when we need it, just in time. It has to be value-based. High quality divided by cost is value equation. Suddenly, what's happening is volume, variety, and velocity of data that's coming upon us is just exponential, growing literally each and every month. What that means is researchers, clinicians have more data and information to digest very quickly and come up with better ways of delivering of care. This force has been in making for many years. As a matter of fact, in the 50s, when our state, Minnesota, was cutting edge when it came to innovation, technologies, there were data points, but they were mostly in-hospital data points that were coming from the point of care. Now, what you've seen over the last 10 years, actually, since 2007, when we had these handheld devices made available, and the first device was announced by Apple. What you're now suddenly seeing is consumers in every walk of life consume more data. And when it comes to healthcare, you're not far behind. People are sending information and data that's coming from open source about us. And it ties into how care will be delivered in the future, because the clinician has to take into consideration not only research that was available in the past and the knowledge creation, but the new knowledge that is coming because of the data coming from different points about the individual and the person. What's quality consideration that I've talked about? There are financial considerations. This past year, we saw major delivery systems taking a huge hit financially. Of course, the government came in and helped. Many institutions have faced that challenge. There's also the Internet of Things that we've had, enormous amount of discoveries in our state. But it's just not that. What I call is the future is digitization of everything. Just as IoT, there'll be DOE. What that means is everything is digitized. And therefore, that too will have an impact. IoTs help the physicians and clinicians to improve the practice. Digitization of information and data is going to redefine how we look at the person and the patient. Of course, the speed of innovation by itself, the technology, the way it is moving fast, is also amazing. That exponential knowledge, we live in this exponential era where information is just coming. Therefore, innovation is coming upon us. mergers and acquisitions. Non-profit institution acquiring a profit-making institution, profit-making acquiring another profit-making, merging. And this merger and acquisition phenomena has been happening. If you go back and look at the numbers over the last 3 to 5 years, just at a constant speed, there's billions of dollars that are being exchanged, and companies are consolidating, finding new ways to deliver care. It's all about the patient. Okay. So when you look at these changes that are happening at phenomenal pace, question before us is what is the future and what are the opportunities? So what I've done over here is given you a few models just to talk through, and then we can have more discussion. About 300 million Americans go through the care continuum each and every year. By show of hand, how many of you have visited a doctor, clinician, seen someone, or your family member has? I'm curious. 300 million Americans go to, over the last 12 years, being seen by a clinician. $2.5 trillion of this $3.5 trillion healthcare sector is spent right there, from preventive care to palliative care. Huge amount of expense. Whether it is government-funded programs or privately owned insurance coverages or firstly paid coverages, that's a huge expense. What we've seen over the last year is because of this disruption caused by COVID-19, the coming together of the payers, providers, and government, the renewed objective that it's about patient care. Patient has to be at the center of the care. So the why is because of all these disruptive forces and how change is happening. What is where the convergence is happening in terms of partners playing together. If these partners had not worked together, trust me, COVID-19 would have made more havoc for our country. They rose to the occasion and they worked together. And I saw that firsthand as the director of the Agency for Healthcare Research and Quality. I spent 4 years of my life in Washington, D.C. And finally, how is important for us to know. So I've synthesized that into 3 areas. It has to be more and more about the patient, because the patient is not just demanding higher quality care, because there's more information and data available. For the better part of healthcare, our care has been focused on a clinical approach, which is only 10% of the full wellness of a person. 5% is environment. 15% is social determinants. So the person have a housing, they have food, the right place, can they be transported quickly? 30% genome, 40% behavior. A clinician never had all of these data points in the past, because the system was designed to react to the clinical focus. 100%, everything is 80/20. I'm not saying that a physician, but there is an institution that looks at you from a clinician, from a clinical solutions perspective. So the question? Talk about that.
Yeah,
please. By the way, this is an interactive conversation, so please don't worry about the slide deck.
You rightly mentioned that. So clinicians or clinical hospitals contribute 10 to 15% of the total healthcare of the person. So I just want to understand with the data which you have presented here between preventive and palliative care, which is $2.5 trillion, and how it's compared with the financial data of the curative care.
I don't have the breakdown of those numbers, and I'm sure from a researcher perspective, we can try and figure out how much is really preventive, how much is in-hospital care, and how much is really palliative care. But the care continuum starts literally from prevention all the way. So can we get you some breakdown? We will. I don't have those numbers with me, but actually look at the complete continuum. You're born, and as a matter of fact, there's evidence that when a woman is pregnant, there's a prenatal care as well that can the health of the person. So imagine all the ways to the end. not everybody will receive care at any point in their lives. The important part to know is that the care continuum is literally from using prevention and prenatal care all the way. Did that answer your question?
I think I look forward to that data. The market is, US market is more deviated towards curative care. And you rightly mentioned and pointed towards curative care. Because I think with this kind of disruption, I think market is going to move.
If you look at the Medicare population, more and more people have comorbidity, multiple illnesses, right? And that number is increasing. The diseases, care issues that are emerging every day. Mental health is an example, which was totally ignored, now becoming a significant factor in the wellness of the individuals. So let's park that question because it's a very good question. Because once you know the data point of this breakdown, you can, as innovator, come up with solutions and ideas to improve that piece.
I mean, the one picture way to think about is like if you kind of think of the hospital sector as mainly just a curative, right? That's like the largest section of the healthcare spending, like 30% is hospital services, 20% is physician services. Again, to what extent that's preventive or not, I don't know. But when you think about these big bucket of spendings for caregiving, that's like hospitals and physicians, that's like 50% is that. If you're thinking about like technology and pharmaceuticals that are more big innovation piece, that's a smaller pie of the entire, 2.53 trillion dollars. Yeah. But it's good. It will be good to say like what percent of the physicians is more preventive. I don't answer for that. Yeah.
But that's a very good question. And finally, over here, what you're seeing is innovation is going to be king going forward. Innovation has always given America a competitive advantage in the global economy systems. It will continue to shape going forward. And then, of course, when it comes to technology, how it's applied to re-engineer the business processes will become an integral part of improving the care delivery, making it better for all of us. Finally, I want to share this chart with you as a use case. Last year, when the disruption happened, delivery systems had to quickly respond to the new realities. The new realities were the hospital capacities were 100% occupied, not enough patients who had comorbidities and other illnesses could not really go and get taken care of. Telehealth emerged, and telehealth is something that has been around for 50 years. Technologies have been in place, but somehow there was no tipping point for this to emerge as a solution and into a very applied format where people could use telehealth as a way to improve the delivery of care, not just for COVID patients, but the patients who were at home who could not come. What really telehealth really is, in a very small way, take the technologies away for a activity. It's basically using the old technologies and combining with the new digital age technologies that have been emerging and have were fragmented and coming together. And the creativity came from the leadership. They said, how do I use telehealth as a new mechanism of developing care, just-in-time care, and leverage the advantages of emerging technologies, old and new, to make care better for the patients. It was a huge challenge. I have a lot of reading material for you there. To go to the first section over here, there are examples of what Dr. Gary Kaplan did in Seattle, Washington State. He was the CEO of Virginia Mason, a very preeminent delivery system in that area. But he's been an innovator forever. He's one of the only CEOs I've ever met in my life in the healthcare sector where he takes his senior executives to Japan so that they can learn TQM, total quality management, So initially he had a lot of pushback from physicians and clinicians. They said, well, it doesn't apply to us. That's something that only automobile industry should be thinking about, just-in-time delivery, continuous quality improvement. It doesn't apply to healthcare. He said, no. Even his board members would go to Japan and get schooled and trained in what TQM was about. He was already doing that. But when COVID-19 hit us, Gary Kaplan became one of the first CEOs of a delivery system to start thinking about how to leverage telehealth. There's a lot more detail available in the meeting assignment. Another data point that you need to look at is making a dent in the $1 trillion problem. Another physician that I had a chance and honor and privilege of working closely with is Peter Pronovost, who is now in Cleveland. He writes a terrific, compelling article talking about out of the $2.5 trillion, there's a $1 trillion fraud, waste, and abuse problem. Has been in the healthcare sector forever, but now it is forcing the whole ecosystem to think differently about it and saying how healthcare research can help in some of those areas, how practice improvement by leveraging technologies can help improve the system. So going forward, what I'm saying to you is really does not matter what your focus is as a student who just wants to know a little bit more about healthcare. As a clinician, as a practitioner, how you want to position your practice in the future, whether you're just interested in the topic or recruiting CEOs. What you're looking for is the kind of people who can lead in a new system and keep America's edge, competitive advantage preeminent in the future as well. So with that as a frame, let's have a conversation. Questions, discussions, observations. I'm looking to learn from you as well, your insights, and everybody would have an insight, whether as a patient or as a practitioner or a student.
So that's the opportunity. To me, it seems like a tool to help with triaging and like assessing, to help relieve some burden by having instead of going to a physical space, like meet, digitally. But I have a hard time seeing beyond just like visiting a primary care physician over the internet or having a consultation with like secondary or tertiary sort of care.
I'm going to turn to, we're lucky enough to have with us a clinician today. So I'm going to turn to him and say, give us a practical good example from your perspective. I can give you other examples, but I'd rather have you talk about it.
Yeah, good question. So just a little bit of kind of where we are now compared to how we were. We were essentially, like you said, nobody was we had telehealth, but nobody was really using it. I think the VA might have been one of the healthcare systems that was using telehealth more than other systems, but still not that much. Majority were all inpatient visits, experience. And then the pandemic happened, and essentially everything shut down. And there really wasn't the infrastructure to have like what you would think of telehealth, like video visits and things like that. It was mostly telephone visits, but then very quickly that wasn't very good for patient care. And then also I think there were some reimbursement issues. And so then we very quickly ramped up to getting video capabilities. And that's kind of where we've been since, early on in the pandemic, is doing a lot of video visits. Now we've started to do more in-person visits. But it's really, I think almost everyone is doing pretty much a hybrid model. And so what do you miss out on telehealth visits that you would on an in-person visit? Well, the connection of, seeing somebody face to face. The physical exam, which is debatable how much information is gotten from a physical exam. And so those are really the big things that you're missing out on. Where some of the things that you're gaining, you're probably able to improve access for a lot of people. It's also a lot, so I work at the university. It's a lot for a person to come in, find parking. You have to take a half a day off of work. Instead, I see a lot of patients when they're just on their lunch break. Which I don't know if that's good or bad, but that's what's happening.
And now add to all of that, the new technologies and solutions that are available, whether it's a wearable or whatever. If the patient is at home, patient's pretty much so with all these devices and the new apps that have been created where literally data by the moment, temperature, you name it, sleep pattern can be transmitted very easily to the care provider. A better view of what the situation is. So the diagnostics will improve very significantly and change in the way they take action. It will hopefully reduce the cost as well. But government had to intervene and make some changes in terms of reimbursement policy. CMS came about very quickly to make changes in the system.
I had a question for you, Gopal. So along that, I imagine, since we can't do the physical exam on video visits, although if we can get vitals, that's helpful. A lot of times you can't ask a patient, please tell me your heart rate, and tell me your blood pressure. You wouldn't necessarily trust it anyway. I wonder if there's been anybody that's looked at, has there been more spending since the widespread adoption of telehealth on things like CT scans and imaging things, essentially substitutes or surrogates for a physical exam, albeit much more expensive? I don't know the answer to that.
I don't have the right answer for you because this is
It's a
something
good
that
research question.
I'd be curious, I would imagine.
New data is coming about. So the researchers are looking and asking those kind of questions and saying, let me analyze what's happening. What's the correlationship between care and, again, as you said, use of technologies as well. So there are unanswered questions.
No, I don't know anyone who has looked at that substitution effects. Like you're basically saying, what are some of the things that are substitutes to physical exam, or are the doctors overusing some of these imaging and testing and stuff? I think that's a great question. We can now see with the data. So I'll bring it up.
And anecdotally, I think I'm much more likely to order imaging studies if it's strictly a telephone visit,
right,
and then less likely if it's a video visit, and then less likely if it's in person. But that's just my experience.
That's the excellent part, amazing part of MILI. Having housed where it is and having the researchers being able to ask these kind of questions. And there are agencies and organizations that are grant-making agencies that would fund these interesting questions. And so we know better as to what works and what does not work. The area that my agency, the Healthcare Agency for Healthcare Research and Quality, was focused on researching or providing funding for grant opportunities for researchers to see the healthcare delivery system. It's more focused on systems research as opposed to NIH, which is focused on biomedical research for new cures. ARC was focused on new of care delivery. Cure and care are two sides of the same coin. So your question is brilliant, and I'm hoping that the researchers, Pinar, would ask these questions, and university obtain funding to really promote that kind of work.
So you have mentioned it's how the outcome is going to affect. I think we should also think, once we're talking about physical examination, patient is coming to the hospital and some infection is there. So when patient go back, he also go with hospital-acquired infection. So we have to also check. We should see that how the outcome of the patient is coming to the hospital, not only examination, but many other factors like coming to the hospital timing and cost, as well as the infection which patient take it back. That's another factor which we.
Yes, I think what will happen is that as a result of COVID-19, it'll just explode the research possibilities, because now a new ecosystem is being created. What works and what does not work, we do not really know. By the way, one of the things that I did when I was at HS last year was to put together a request, literally a very substantial amount of grant opportunities to ask these kind of questions. What works in telehealth, what does not work? Actually, my request was 100 million. Don't quote me. And the other area that my team put in place was digital healthcare research. That's another area where research has not been done enough. What's missing is because if you have digital devices coming up, question is what's working, what does not work, when does it work, how can it be used differently? A lot of unanswered questions in healthcare have been so. The good part is government is investing heavily. The future of health research will change as well. I think so. It has to become much faster. Because research in the past, old model, 10 years or 2 years, 3 years, such a dynamic system, we just cannot wait for that long. Second thing was the research used to be very theoretical to make sense of findings that come out. Now has to be more operational research. So the pendulum is going to swing even in the research area as well, not just practice. And there are correlationships between all of that.
Kyle, to your question, with the telehealth, one way to kind of think about it, I think, is that, this nice, easy way to see your doctor. But I think what it is really opening up as an opportunity is with the advent of all these other things, like Gopal is talking about the devices and the apps and things like that. It has that, and now telehealth is reimbursed. And when you combine telehealth with all the other tools, it actually really, I think, opens up a new sort of era of more patient agency and real-time information from patients, right? So, when you think about, you're very committed to like the patient report outcomes kind of thing, Gopal, I know, and similarly, like really being able to learn the patient's voice and engage that patient's voice, like through these digital technologies and incorporating your clinical workflow. Like telehealth actually facilitates that in an easier way. And so, as a researcher, I'm always frustrated working with the secondary data sets. Like I look at medical claims 2 years past and I'm like, okay, but I can learn something from it, but I really want to know like more real-time information, right? But with these tools, and you have the opportunity to use that real-time information from patients to see how something is working out or not working out or having a side effect. But
I like that answer because that's kind of more of what I was trying to get at, is like, how is care actually being transformed with this? Because on the surface, it just seemed to me like a workflow sort of tool. Like we're going to optimize, having a manufacturing background, it was like, we're going to optimize our process, right? We're going to make sure that we can get more people in, that we're increasing the efficiency of the staff. But talking about, some of these other devices that collect information outside, I can see now like how it's actually being transformed. Also really interested about is potentially the use of that information collected by things like wearables and trying to maybe like promote healthier habits as well. I'm glad that you mentioned that like 40% of one's health is behavior, because yes, I think that's something that doesn't really get talked about too often. It's kind of the elephant in the room. But I think maybe with wearables, and you can tell me if this sort of conversation's already being had, but with wearables, there's potential for, tracking, potential for like payers to incentivize and say, hey, like if you wear this, if you go to the gym so many times, if you do these activities, we'll lower premiums,
Absolutely, yes, and that's where so it's providers, payers, and like the government is because government has a huge role, whether it's for research, grants, and or themselves with Medicare, which is increasing. So coming back to some examples, if you go back and look at one of these presentations, Gary Kaplan talks about how maybe just a hardware study that looked at their model, how a patient in Alaska was not well and had diabetes and could not be seen and work with the patient. And the patient could provide more patient data and information so the physicians and the clinicians, not just primary care, but the entire team was put together. And the patient was flown right away and timely response, even with COVID-19. challenges that we've had last year. Another example that Gary Kaplan points out is how they've changed the way patient is seen. What do I mean by that? In COVID-19, we had a huge establishment within delivery systems focused on COVID-19. But you had a lot of physicians, specialty physicians, who were really not optimized completely. So what he did was, by connecting with the patients who did not have non-care patients, he was able to use a diverse group of practitioners. So if a person had comorbidities, they didn't have to just go and see one clinician. They could see 5 people. Questions. So the clinician had a much larger perspective. So it goes back to what you're pointing out. It is totally changing not just the how, but the how as well. And some of these things, I'm going to be honest with you, not even no institution has a complete grasp, because these are all changes in making as we go along. So, yes, sir.
I had another question about legislation. So telehealth has improved access quite a bit. Somebody from War Road, I can see somebody from War Road, they don't need to make a 300-mile trip or whatever it is. However, I can't see somebody 30 miles away from Hudson virtually, because they're across the state line. So I can't practice in Wisconsin without a Wisconsin license. I can't practice in North Dakota, South Dakota. And I think that there are good reasons for that, but so essentially now, and it's pretty clumsy, if somebody is from Wisconsin and they have a visit, we're like, we have to like drive to a parking lot in Minnesota, and then we can have your visit. You know, it's not very great for the patient. We have a lot of visits in people's cars. Do you know if there's going to be any kind of regulatory change to physician licenses? If there's talk about that, how we can expand virtual care across state lines?
Congressman Mark Upton from Michigan, Congresswoman Diana DeGette from Colorado. They've been working over the years. 5 years ago, they came up with legislation for the 21st Century Chores Act. At that time, Vice President Biden was really challenging the whole community to afford cancer. And they looked at many practices, many policies, and they made some changes. As we speak right now, we're rethinking the Cures Act, and they're saying there should be a Cures Act 2.0. So discussions are actively happening. Whether this particular issue has been brought up in the policymaking circles, I don't have an answer. However, if it is an issue that is challenging, I would urge you to write a letter to them. Because right now they are on a speaking tour. They are going out and meeting all over across the country, leaders and people who are concerned about healthcare, to understand what are the challenges so that the legislation can address some of those challenges. But that's a brilliant observation. Because people, it's just-in-time delivery of care. People are mobile, and if you look at the demographics, the aging of the population, there's more care. But at the same time, if you look at the Gen X and the Gen Y, they're very transient. They're moving, they're living all over. The question is, how will that evolve in terms of Epic and Cerner and sharing of the data? There are huge challenges ahead. You make a very good point. Any question online from those folks who are remote? We are tracking your question. Yes, please, and then I'll come to you. Please.
Thank you for the interesting presentation. I have a couple of questions.
Yes.
So when you were doing research, have you come across anything with retail, specialty, private clinic, for example, home infusion? So those things like that, I know is a growing business for them since COVID, because as we know, the patient is more diluted from hospital, institutional, and they spread out more to the retails and specialty medication, home delivery, all kinds of things, and home infusion will be a lot of patients registered with that rather than coming to the infusion center and get it, get the infusion. So, and if you found some of the data about it, can you share it with us? to see, is that really a growing business? Because I see it's growing, but there might be some hinders.
There's always a lag between what's happening in the real world and the questions emerging in the research agenda. So the research agenda of researchers also changes and evolves as new data is found, because as Pina was just pointing out, if you have data, you're not missing and situation currently. But there's not enough data on a broader issue, because in the past, we were looking at a very small pie of the full wellness, which was clinical care. There was a lot of data that has been available. It's a patient safety issue or quality of care. And there were enough researchers looking at them and helping improve the processes through clinical decision support systems. But with the new telehealth, in terms of a usable way, practical way of providing care, it'll just explode research possibilities and research opportunities. Pina, do you want to add anything to that?
No, I don't know home infusion centers per se, but this shift away from hospital has been a very, very big agenda. I think, how can we move people away from the hospital and treatment outside of the hospital? And that just, I think, observing that is definitely a growing business, just doing things remote care.
I know there's some specialty pharmacy, they ship IV bags or some products to the patient, and then in combination with telehealth, the provider will instruct the patient how to insert the bag into the IV pole, and then they just go from there. And then the telehealth help the provider stay on the screen for as many hours they need to monitor. And that's it. So the patient didn't have to go to the infusion center, but they still get the medication as they plan.
Yeah, I heard, again, these are more anecdotes. I don't know if there's any studies that came out and evaluated these things, but I mean, places like Mayo Clinic, pilot programs where they create hospital rooms in people's homes. And it's like a major control center they have, just kind of monitoring home hospital rooms and sorts of different issues, and just communication with the patient. But this is definitely, I think, a major shift.
Huge explosive opportunity. Again, when you're looking at this discussion today, I'm just pointing out telehealth as a use case. That alone is creating new opportunities, as you can see, from management, research, practice perspective. Just can you imagine, if you were to look at other changes that have happened as a result of COVID-19, that what kind of ripple effect it will have? It'll redefine how care is delivered. And that's the piece that I would like to leave you all with. The grand challenge that we have before us is creating just phenomenal opportunities, whatever your area of interest might be. Whether you want to be a management leader, researcher, a clinician, or a practitioner, innovator, ways of creating solutions. As leadership, they got a grand opportunity to come up with an app. It's called patient-reported outcomes. That was one of the first major ones in the country. There were others, but the research team put together a solution, an app, so that the patient's voice can be heard, which is going to be key as we move our care model from just clinician-centric approach to a full 100% 360-degree care.
But I would add to that, I think one other area that needs to be connected to all of this is the payment. Payment has to adapt to this, right? So you can collect all this cool information from the patient and kind of find out how well they're doing and how well the treatment may be working. Eventually, it's not going to have an impact if two things don't change. One is that data becomes actionable from the provider side so that the provider can respond to changes in health and the real-time data reporting. And two, if the payment models don't change, to be able to sort of reward, or sort of like the value-based payments, but reward that things that are working well, in patients, care path. So you can imagine, like, that's my like big goal vision, like going like, you can imagine a payment that basically pays for, as the patient is reporting, you have a device, and that the device, and you're reporting that you're doing well, and that device gets more payment. But if it's not, then the device doesn't get as much payment.
Absolutely, and then there's a organization called CMMI, which is part of CMS in HHS family, that is focused on looking at payment models all the time because there's changes happening, so it has to be very dynamic. But one area that I was very impressed myself was how we reacted fast with speed when it came to telehealth use reimbursement policies that came out very quickly. But again, the government moves very slowly in terms of, and of course, then we have to work with the insurers as well, the payers, in terms of coming up with better models. So as these new ways of looking at delivery of care happens, it'll have an impact on payment side as well. One question, yes, sir.
Yeah, so I was a researcher at Mayo, and one thing that they were really proud about was, people from around the world would be showing up and need that life-saving surgery, so they come to Mayo, with sent home. But with Internet of Things, digitization, telehealth, that's a very strong decentralizing effect. So going beyond data gathering and legislation, I think the time is coming with like 5G and all of that. They can actually perform an intervention on someone in another continent. So surgery would be one of those examples. We have robots now that can do that.
Yes.
So are there any other, I guess, to speak to the question, are there any other complementary technologies that you see that are going to change the way that we structure healthcare in the US?
There are many technologies, many. No one technology can solve the problem. And as you're well aware, in terms of what it takes to have a patient walk out of your clinic, it's well and better than when they. And grand challenge before us is that with so many areas of innovation happening currently, which institutions will be able to use them, leverage holistic approach. So Mayo Clinic is a brilliant example of how they take a more holistic approach to delivery of care. And there'll be institutions like Mayo Clinic, Kaisers of the world, and others who will be able to come up with new ways of literally transforming the care delivery. I don't see one technology or one innovation solving the problem. The healthcare delivery system is very complex because human anatomy is very complex. And as we discover and find new comorbidities, the whole how we handle them will be different. But you're right. There are technologies available. Are they mature enough to be implemented? Do they take time? Yes. Yes.
Sort of adding on to the discussion that we're just having. Most of telehealth actually concerns clinician and patient interactions, but then another bring up was like cooperation between different medical institutions. So what I've heard is that there's some upcoming talk about clinicians actually cooperating, clinicians working in different facilities, cooperating with each other within a set frame of network. So we already have these integrated delivery systems where they go under like common management, they share patient data, but they're taking that to a different level, like where they're actually having remote operations, just like you just mentioned. And what I wanted to ask, maybe just everyone in this room, because you all have such different backgrounds, what would be the major concerns when we're trying to actually implement this kind of direct interventive between these institutions? Because it's more like, it's not just about accessing the patients, but it's not actually about operating together. That's what I wanted to discuss maybe.
Anybody would like to take a crack at that question?
I could try. Just one of those technologies that I've been thinking about is virtual reality. So you can, like, there are systems that are coming out that you can put on, a headset, other person, whether they're in that area or not. So you could sort of perform a surgery together or some other intervention, not together, but together in a sense, So yeah, I think a lot of these technologies are sort of aiming towards the ability to do that. So,
And by the way, I want this kind of exchange amongst you all because this is a learning experience for all of us. It's such a dynamic field that you may have an idea that I've never heard of, which is good. Make me better and smarter. I'm here learning just as you are. Any other question? Yes, you.
To your point, I think there's a few things that I think of. One is just the technology. Technology presumably get there. Right now, I don't think it's quite there. But then just logistically, it was a nice idea to get like 5 providers together in all conference about a tough case or a patient or whatever. But logistically, there's just not much time to do that, and everybody has their own patients, and it's kind of there's this like I think it kind of comes from like House, where everybody gets in a room and talks about the patient. It's kind of this romantic idea, and they all figure it out and fix it. And it doesn't happen all that often. There are conferences, but it's usually within your own institution, which is another kind of red tape. You need to have privileges at a certain hospital if you're going to be practicing, or I don't know, maybe even giving advice. Similarly, like I mentioned, across state lines, country lines would be even more difficult. It's like somebody somebody from Europe can't come and practice medicine here without applying for the license, and so it's hard enough just across state lines to get privileges to practice, but across country lines would be really tough. So there'll be a lot of just logistically red tape to break through in order to have that kind of collaborative. And then what'll drive that kind of collaboration will be, are you incentivized to take the time, which is reimbursed? Because so I do GI, like doing colonoscopies pays the bills, but in a room with a bunch of other physicians talking it's good, it's probably valuable, but it's not what's rewarded. It's not what's incentivized. So I think that a lot of this will change as telehealth and virtual health have more of a foothold.
And by the way, it's not going away. It's not going away. So as future leaders, you've got to take that into your consideration as leaders. Yes.
I don't know if I totally have the question correct, but I think maybe not as some technology. Hear your thoughts on too is of side, not just when someone's like maybe had a traumatic experience, but as a annual part of checkup.
From what I think I've learned about is there's a lot of behavior change tools and resources that can help with adhering to medicine, behavior change that might help with prevention or reversing chronic medical conditions. But there's not like an integration of behavioral health in medical care in the same way that it's almost like we're not leveraging everything that we could be to get better outcomes.
You are so much on the mark. I would talk to the Commissioner of Health and Services, social services that provide, but there's no link and connection with the systems, because the clinical world and this is the social services. However, the disruptors are demanding for the systems to change and think differently. We do talk about integrated delivery networks, but what you're talking about is the next level, version 2.0 or 3.0, totally redefining what an integrated delivery network would look like. It has claims piece, it has financial reforms. 40% is wellness is behavior. And that's something that NAM's report pointed out many, many years ago. So it's not something that's new. We have known about it. There was no tipping point that forced us to think differently and change how we practice. Any other final couple of last questions?
Yeah, Gopal, this is Tarun. I'm online. wanted to ask, I mean, with the advent of the Cures Act, wanted to understand the information blocking provision and the connected devices and the home care. Like, what do you think are kind of what's working, what's not working with the information blocking provision that we have in the Cures Act? If you could shed some light on that.
The point is well taken. And again, as I said, Upton and Leggett are right now literally going out nationwide and on the listening tour to find out so that people and experts can really point out the real problems and the challenges they have. These are good ideas. We know what needs to be done, but they are stumbling blocks. Data sharing is a big problem. So will Cures 2.0 address that? I don't know. But I think so. There's a unique opportunity for you because each and every one of you is a leader. So you don't have to wait for some CEO or somebody, some giant figure to put that idea forward. I would urge you to write a letter to Upton and Leggett and point and submit your observation. So I'm hoping that this is a practical discussion today where you can do what you think needs to be done and take action, participate in that new ecosystem development. So I don't have a perfect answer for you because I really do not know what the provisions will be in the new Cures 2.0 Act. But right now it's being talked about very actively. And something will happen, whether that will become law in this year or next year or the year after, I don't know. But the conversation has seriously started. And I'm hoping,
thank you.
Because in my conversation with them last year, I had a chance to visit with Upton and Leggett representatives, and if I recall correctly, Representative Diane Leggett said that one thing that they missed out in the Cures Act 2016 was looking at CMS and CMS reform. Looking at my agency's work at that time on focusing on health services and health systems research. So they're rethinking based upon the new realities. And by the way, new realities have been emerging over the last year. I won't be surprised if the vision they had in December of 2019, when they first talked about Cures 2.0, and I would urge you to do Google search on Cures 2.0. Started talking about it in, I would say, late 2019. And that conversation will evolve. Because this past year has changed the game on how they will be delivered. It has to take into consideration what you're pointing out as the behavior part of it. My hope is that you all will become part of that leadership agenda. The nation needs you. Whatever your area of interest might be, the country needs you. With that, I'll say thank you so much for the opportunity to come and talk to you today. I've learned a lot, the many unanswered questions, which will give me a chance to go back and do some research of my own as well. So thank you all.
Attends today. Thank you for Gopal for coming. Just a little shout out. Our next DIR session will be November 15th. And Dr. Arkel Giorgio is going to be coming in. She's the Chief Health Officer at Start the Hearing. So we're going to start communicating about that event. It'll be another lunch and learn like we had here today. She'll be sharing some insights about the hearing space. It's a space that I'm very passionate about, and I think we can probably advocate some more out there for the hearing space. So hopefully we'll see you then. Otherwise, thank you for your attendance today.